I wanted to start this session really as an introduction to really the core members of our adult congenital heart disease team. So you'll have a chance to meet us and hear a little bit about what expertise we bring to an ACHD program. It really is a 10,000-foot view of ACHD accreditation, though. In 10 minutes, I'm not going to tell you everything you need to know, but I hope to introduce some things. Not everybody in this audience is looking at going through accreditation, but this will give you some idea of how we organize care in adult congenital heart disease practice. After over 25 years in our adult congenital heart disease center, I do a lot of reflecting back and seeing timelines, and I'm not going to spend a lot of time on this slide. I could probably spend an hour doing some rough reflections, but I will restate something that Jamil said, in that we always pay tribute to our founding director, Joe Perloff, who really saw this specialty as something that was core to seeing good outcomes in these children that were having surgeries in the 1960s and 70s. So it's been almost 50 years that we have seen that reality come to fruition, and I did a lot of looking at where we focus in each decade that I've seen come by, and it really has evolved in an amazing way. It has come now to this last decade to a lot of shared research. We've learned how to pool our research efforts with other centers across the nation and internationally, so that we finally are in the forefront of evidence-based practice, which is something so critical to being able to put out there to the world how we manage patients and where patients should get their care. And now, in current day, we are seeing our first geriatric adult congenital patients. Really, it's kind of a growing population, quite honestly. There are many who have now reached senescence and have their own issues. So we then kind of step towards the accreditation process and board certification as a way to organize our efforts to keeping them with us as long as possible. I just kind of brainstormed on some concepts that I think are important in comprehensive care, having a centralized hub so that patients can come to one center where all their specialists, their multidisciplinary specialists as well as subspecialists can be located. Regional, so that we reach out. When we are in a location like Los Angeles, there's wide ranges of patients throughout our surrounding area, so we have to be prepared to reach out. Jamil went over a lot of these concepts, but the few that I will emphasize is organized and connected. If you do not have a very well-oiled admin support staff, it doesn't matter how caring and wonderfully perfect your providers are, patients will get lost and they won't find their way to your center, or they won't be able to stay in care, having access to care not just from as easy as making an appointment, but also getting insurance authorization. So I will emphasize that time and time again during my brief talk here, that an admin team should be where a center spends some money to be able to make sure that their patients remain in care. Dedicated relators, I'll bring that up because I think most of us who have taken care of adults with congenital heart disease know that everybody who is coming into contact with them, not just the ACHD providers, but the subspecialists and staff need to understand that these patients, they oftentimes come with a lot of their own preconceptions about care and know a lot about their care and can spot a faker a mile away. So once you have those substrates, we organize care in a way that the Adult Congenital Heart Association, which was developed in the late 90s, it was a patient and family-driven advocacy organization that really kind of meshed with providers to have a really important role in how we have evolved in ACHD management over the last decade and a half, and really improving the quality of ACHD care by increasing access to highest level of care and developing standards to allow patients and families to identify physicians and facilities providing that care is their main strategy. I will point out that their disclaimer on their website, which I've noted a few times in this slide, shows that they have a clinic directory that varies widely in how self-reported centers say how many patients they see and how much experience they have. So 109 centers are reported on that site in the United States, but they see patients at a rate of maybe 27 patient visits a year, up to already to 3,400, which varies very widely, but probably less than a dozen centers really see patients at the level of over 2,000 patient visits a year, which is it's really where we're going to focus in on how accreditation impacts those comprehensive care centers. So the strategic plan for the ACHA was to get accreditation up and running. In 2015, they piloted 5 centers, and in 2016 accepted applications from, I think, at least 15 other centers, and are currently in the phase of site visits to be able to become accredited. They have yet to announce all the accredited centers. I know there are some out there that, but the ACHA will not give me those names. You'd probably find that on their websites, but you'll see a lot more in the coming year. And they have some very impressive endorsements for supporting this accreditation. So the core components, a very brief overview. In order to become an accredited center, you have to have ACHD cardiologists that are either board eligible or board certified, at least a board certified as the director and main cardiologist in practice. A mid-level provider, an NP or a PA is a requirement, an RN nurse coordinator, and a policies and procedures for inpatient and outpatient care and transitional care have to be in place. And all the imaging options, CT, MRI, echo, and exercise testing have to be available. Then you have options to go towards comprehensive care or a care center. And really the two differences here, you still have to have all those core components, but the ACHD Comprehensive Care Center has to have 24/7 coverage for all of those subspecialists: congenital CT surgery, interventional ACHD cath, EP, heart failure and transplant services have to be on site, pulmonary hypertension services and reproductive services, and a social worker. The ACHD Care Center just has to have a policy and procedure in place to refer to those subspecialists. But both of these accreditation entities have to have the core components of those core staff members as well as processes in place. This is a busy slide, I won't go over it, but basically it's on the ACHA website. Again, you can actually, I put the entire accreditation packet in the syllabus, but it's clear to see there's a lot of processes that go on in the application, and really administrative support is essential if you're going to get through that process. And it will take probably a good half a year to get to the point of site visit. There's a lot of paperwork involved, and I thought this was a good reflection of it's real documents, and it does take a very good a core team to be able to put all this together. Dr. Abelhusen talked about subspecialization. I'm not going to get into how you do it from a physician standpoint, but I'll emphasize this point, that nurses don't have a training pathway for adult congenital heart disease. So it is important, I think we have a lot of nurses in the audience today, to know that centers at the size of ours are there to be able to provide preceptorship to growing centers, and we invite nurse practitioners and nurse coordinators to spend a day, a week, a month, whatever their program can support. And I think all of my colleagues across the nation who work in large programs are willing to do that, because it really is otherwise on-the-job training, whether you come from adult cardiology background or pediatric cardiology background. There's not a clear-cut path to be able to train. We all have certain ideas of what our basic competencies must be, but there's not a clear-cut way to know how to move people forward through that process. Our team, you're going to meet most, if not all of them today. I am going to have the pleasure of introducing some of my dearest colleagues, and I'm going to focus first on Linda Hauser, who is my NP.